Sorry to interrupt, Sada. There's no sound.
With dental healthcare providers worldwide. That's what we do every day. It is what drives us and fills us with passion. Driving breakthroughs and exploring new ground for 60 years. Our roots are recognized as a leading innovation and quality brand in dentistry. Innovation that's backed by scientific evidence, legendary Swiss engineering, and precision. We want to push the boundaries to enable the next generation of dental care. Welcome to the Straumann Group. Our brands and partners even more committed to dental care and excellence. Through innovation and excellence, we make better dental solutions available to people to deliver more smiles. Education is the foundation of our success, together with the largest dental scientific network. We provide an inspiring working environment where talented people can excel, so that we can achieve our goal in aesthetic dentistry. The Straumann Group, a powerful combination of great brands. We are Straumann, the gold standard in implant and aesthetic dentistry. We are Neodent, progressive dental solutions combined with affordable economic value. Imagine creating millions of smiles. Imagine helping people look good, feel good, and enjoy life. Imagine making people's lives better every second of the day. Imagine inspiring thousands of talented professionals worldwide who serve more than 200,000 customers in over 100 countries. Imagine pioneering, empowering, and partnering with dental healthcare providers worldwide. That's what we do every day. This is what drives us and fills us with passion. Driving breakthroughs and exploring new ground for more than 60 years. Our roots are recognized as a leading innovation and quality brand in dentistry. Innovation that's backed by scientific evidence, legendary Swiss engineering, and precision. We want to push the boundaries to enable the next generation of dental care. Welcome to the Straumann Group. With our brands and partners, we're even more committed to global dental care and excellence. Through innovation and excellence, we make better dental solutions available to more people to deliver more smiles. Education is the foundation of our success, together with the largest dental scientific network worldwide. We provide an inspiring working environment where talented people can excel, so that we can achieve our goal to be the leading global provider in aesthetic dentistry. The Straumann Group, a powerful combination of great brands. We are Straumann, the global gold standard in implant and aesthetic dentistry. Progressive dental solutions combined with affordable economic value. We are Medentika, prosthetics perfected, engineered and made in Germany. Clear Correct. Clear, simple, friendly. We've combined all of this expertise into one global group, based on a pioneering culture that promotes creativity and learning. We unite global reach with individual talent, experience, and identities on a remarkable journey. Our inspired professionals are committed to delivering uncompromising quality. We take an holistic approach that goes beyond implantology. Straumann Group, united for global excellence in dentistry.
All right, good evening and welcome everyone. My name is Kaylee Bartho. I am the marketing manager for Straumann Group South Africa. I work closely with Talia across all of our wonderful brands, namely the Straumann Dental Implant System, Neodent Dental Implant System, Medentika Multi-Prosthetic System, our digital solutions portfolio, which includes 3Shape and Rapid Shape, our biomaterials portfolio, and more recently, Clear Correct clear aligners. As you saw from that video, Straumann Group aspires to be the leading global provider in aesthetic dentistry. With our products, solutions, and services, we make better dental solutions available to customers and patients around the globe. For us, though, we focus on Southern Africa, including Kenya, Namibia, Mauritius, Botswana, and Zim. Before we start, I do have a few housekeeping rules I need to share with you quickly. Please refrain from using the raised hand. Rather, type your comments and questions in the Q&A tab. CBD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access your CBD certificate. The event for tonight qualifies for 1 clinical CEU. We are streaming live on YouTube, so in case you're having difficulty with the Zoom platform, you can access via YouTube. And lastly, do not forget to complete the evaluation after the webinar, please. Enough from me. I now hand over to my colleague Talia, who will introduce tonight's speaker.
Thanks, Hales. Hi, everybody. My name is Talia van Straten. I am the Training and Education Manager for the Straumann Group South Africa. And we are very happy to be involved in another SADA webinar, a proven, successful educational platform for all our local dentists in these very, very unusual, awful times, actually. Tonight, we're going to talk about dental implant complications, failures, the timing of implant therapy, and fixed restorations. So it is my immense pleasure to introduce to you Dr. Ridhwaan Haffajee, a restorative dentist at Matrix Dental Specialist in Century City in Cape Town. Ridhwaan originally comes from Cape Town. He has picked up and moved down to Cape Town. He graduated at the University of the Western Cape in 2011 and went on to complete his community service via the South African Military Health Services in KZN. In the lead up to qualifying as a prosthodontist, he decided that Cape Town again was the place to be, away from mom's cooking, much to, I think, her displeasure. And he started his Part 1 exams, his postgraduate diploma in implantology, and he is now currently completing his prosthodontic thesis. He is extremely actively involved in the ITI, which is the International Team for Implantology, the South African Academy for Aesthetic Dentistry, the Islamic Medical Association, amongst many other programs and groups that he's involved with. So as I said, I'm extremely pleased to welcome you, Ridhwaan. I hope that you will bring light and a lot of insight to our participants tonight. I'm sure it's going to be a wonderful hour or so that we're going to be spending together. And with that, I hand over to you. Thank you.
Thanks, Talia. I'm originally from Durban, so if my mom is sitting in and watching, you're going to have to deal with her for saying that. I'm not from Cape Town. But needless to say, I'm not sure how much of insight and enlightenment I'm going to be able to provide at the end of today's lecture. Probably a little bit more confusion and if not more questions, because I also realized while putting the lecture together today that the title of the lecture was slightly ambiguous, basically timing of implant therapy and fixed prosthodontics. I think the specific of it is based on continuous physiological eruption of teeth and midfacial development. I think I'll be the first to admit that it's probably one of those gray areas of implantology that we don't always talk about. We're probably shy to talk about it. I think because we don't always have the answers in terms of avoiding it. But I've been fortunate enough to, both in private practice now through my training, and also on a daily basis, I get to obviously treat patients, but I get to engage with practitioners on various levels of implant treatment. And I think, with all due respect to many of the practitioners out there, one of the most common terms that I hear is that when someone's getting into implantology, it's very much on, I'm going to start with the easy implant. And the easy implant, that's a relative concept for different practitioners. Could be anything from a posterior to a premolar to an anterior. And the most recent comment I heard was that I like to start with the easy implant, which is the anterior implant. And that's exactly why I've put up this photo, because it is the anterior implant and the results look fairly decent. One I think my patient's quite proud of. But as I've started investigating through the literature, I realized that what's easy is today, or what looks good today, how long is that going to last? Because as I'll speak on later on, there's only one guarantee in dentistry. Needless to say, I think this is almost something close to what's the dream or the ambition of any implant dentist. Papilla, soft tissue stability, aesthetics, color, shape, so on and so forth. And when you remove this crown at a recall visit, you get to see the nice pink soft tissue with a little bit of bone grafting material that was left behind. But all in all, a result that we aspire to. And once again, I'm only in practice for a year. And Talia mentions that we're in crazy times, but I think we can safely admit that we are now in the new normal of crazy times, because 1 year on and we're still having Zoom talks, which is fantastic. But needless to say, 1 year is still nothing that I could ever judge my clinical skills, competence, or my long-term ability, because long-term ability would really go back or go forward to 10, 20, 30 years. My uncle in Durban, Dr. Vyad, he always tells me that the hallmark of a good clinician is that he would be in the same practice for over 30 years. And I think after 30 years, you start seeing your own work come back and your own complications and your own failures. And I think with the access of such high level of dentistry that we have today, that's something that we need to be aware of, that our complications are going to come back to us. And being in 2021, Instagram, Facebook, LinkedIn, I think it's, even if your complications don't come back to your practice, your patients will find you. And I think this is something that started resonating a lot more with me when we start planning bigger rehabilitations, or even the simple single implant rehabilitation. What are the possible complications? And if one of those had to come to reality, how do we work around it? Needless to say, the scope of my lecture this evening is basically going to be the learning curve. I think that all practices go through, all clinicians go through. A case that really got me thinking, looked at the literature, and then this little Dunning-Kruger effect. I think this is the photo that would sum up ignorance. Lots of excitement, lots of enthusiasm, highly motivated, but in terms of clinical expertise, we were literally at the bottom of it. We starting our practice with literally a white box, and I think that's exactly where we're going forward. And I think since that day, I always try to look back at this day when you first get the keys to think, what did we think at that day, and what was our approach at that time, before we get confused and diluted into the whole, for lack of a better term, the capitalist way of thinking in private practice. Because the reality is, unfortunately, there's bills that need to be paid and there's income that needs to be derived. And we are a service-based industry, but there's that very, very fine line, or that gray area, that where we are healthcare practitioners dealing with patients, and the direct consequence of our treatment will come back to haunt us if not carried out correctly. So the learning curve that we all hope and aspire to is very similar to the little snake diagram that A.B. de Villiers has when he's batting. His run rate, pretty much it just goes straight up, and we're hoping that it just goes up, 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 up. And I haven't been around long enough, but I have been around long enough to know that what goes up must come down. And the problem is that when it comes down equally as fast, if not faster. So I think the idea here is to try and see, along the way of our learning, we also don't want to be creating this pathway of destruction, because it is what it is. We do too much, or we can potentially do too much, and we are leaving a pathway of destruction. So one of the first starting points of where this topic was initially brought to me was at the South African Academy of Aesthetic Dentistry. There was a very nice lecture day happening in 2019, and Jeff Patterson spoke there, periodontist up at Gauteng. And his topic was lifelong craniofacial growth, myth or reality. And at that time, in 2019, I think we were pretty much close to deciding whether it was myth or reality. And I think looking now at 2020 and where the literature is, I think lifelong craniofacial growth is a reality. And it's a direct consequence of something that we can't control. It's just because we are adding materials into something that's biological, something that has potential of growth and change that we can't control. And as much as we feel we can control everything, there's some things that we can't, and this is one of them. So yes, if Jeff is listening, it is a reality now. This patient actually came to me 3 or 4 weeks ago, and I think everyone that's sitting in tonight, it's other than all the other clinical findings, the patient wants to have these 2 crowns replaced. And I think at the top of our heads, we could easily rattle off the codes. And this is with me just being 1 year into practice, 8409 times 2 and 809 and 8099, so on and so forth. But what caused this? Because surely the practitioner that had placed these crowns close to 15, 20 years ago didn't prepare those margins at the level that they currently are. He'd obviously prepared the margins at least equigingival, and it would have never been to this level here. What caused it? Because the patients will also say that the gray line never showed. And yes, the gray line will, or the gray margin will start showing for various reasons, but we're looking at the vertical relationship or the coronal-apical relationship of where the margin currently is. What caused it? Could it have been avoided? Yeah, these are the questions that we're going to go through the lecture. Because the other teeth seem to be in a fairly decent position. Those are natural teeth, they're unrestored teeth. So it seems that there's some sort of harmony between soft tissue as well as the enamel. But specifically and directly related to today's lecture, it's one of these. Implant placed, this patient is 33 years old. 33 years old. And he had this implant placed by a very well-respected surgeon when he was 17 years old. And over the years, he said he's had this crown changed twice. He can't remember the exact time, but ultimately this is what it is now. And I think I could say off the bat that this was definitely not the clinical situation at that time, and the patient also agrees. The patient says over the years it has become a little bit worse, but it certainly didn't look like this. So there's 2 components that we're looking at in this case. The first component is the gingival margins, or the crestal level of where the implant should be or where the implant is. And the second component that we're looking at here is the incisal heights, because regardless of how the implant was placed or where the implant was placed, 99.9% of the time, the incisal edges of these crowns should be fabricated coincident, but neither of the two are sitting in any relation of any clinical success, which is concerning. And especially we'll see an extraoral image of the patient later on, that the treatment for this patient, unfortunately, is quite radical. The implant has to go, unfortunately. And it's going to be major augmentation, both hard tissue and soft tissue, a period of wearing some sort of a removable or interim prosthesis before going into provisionals again and then finals. And it's a long journey, and it's something that needs to be redone, something that was done by man that has failed and needs to be redone. And how much of this information was given to this patient at the time of implant placement, I'm not sure. I think also the generational gap of when the implant was placed to this age, I think all expectations of patients would have changed substantially. So it takes me back to the first question of when is the ideal age for placement of a dental implant? Are we looking at placing a dental implant when the patient's 16, 18, 21, when we all become adults and independent and strong, or 23, 24, 25? And we're generally looking at ages based on chronological age versus our general skeletal growth. At 16, have we stopped growing? Or do girls stop growing before boys? Do males stop growing before females? At 18, now we have our driver's license. Are we old enough to now consider ourselves adults? At 21, you have the key to the house. You should be an adult. You should have stopped growing by now. So we very often start thinking of fixed prosthodontics or implant placement based on these timelines, which are very often not related directly to our oral situation or the maxillofacial situation. And if we start sketching back into the literature, and I'm not going to go into the literature too much of detail or the older literature, but I think it was as far back as 1952 when we started seeing that there was change, and there was change that was continuous. Yes, the method of research at that time was quite primitive, very different to the methods that we have today. However, change was seen, and it was viewed over long periods of time. Once again, going again to 1963, once again, it says the significant eruption of the incisors and growth of the dental-alveolar processes were seen in both jaws, the maxilla and the mandible, and it can be concluded that significant changes can take place between the age of 30 and 40 years old. It's important, but somehow between that time and today, we're placing more implants more readily, and we're forgetting the consequence of this process or of the procedure. Coming back a little bit more recently, when implants have become more of a go-to treatment modality, and I say it's a go-to because if I look at, I'm sure most of the practices that do engage in implant therapy, you look at the number of fixed tooth-supported bridges versus implant restorations, that number is obviously declining. So in terms of single implants in the upper incisor region and the relationship to the adjacent teeth, with an 8-year follow-up, there was obviously changes. And of importance to consider in a single implant therapy is that a fixed chronological age is no guidance for implant placement due to a slight continuous eruption of adjacent teeth post-adolescence. And I highlighted the word slight because, once again, what does slight mean? And I'll reference a few articles later on where the terms are a little bit ambiguous. And I don't think they're ambiguous because they're trying to hide anything. I think they're just ambiguous because to definitively put a number to it seems to be very, very difficult. But what we really want to know is slight relevant? How much is slight? And at what age can we avoid slight? Because the consequences of slight, as we've seen already, are catastrophic. Because this is the same patient. If we had to tell this patient at the time of implant placement that his chronological age does not relate to his development of his maxillofacial structures and there'll be a slight change over the few years, he would have said yes. But slight in this regard is quite large. So I think just to recap everything that I've been saying so far, what I'm really getting to is that the concept of continuous eruption of teeth. It's physiological and it occurs throughout life. How long into life? We'll touch on a little bit later on, but the literature shows this change going all the way up to the 5th decade at times. It means a patient that is 50 years old is still showing signs of change. Something important to know that all of us have probably become aware of it is the difference between vital teeth and ankylosed teeth. And with specific reference to dental implants is that a dental implant does behave as an ankylosed device in the mouth. It does not move, while everything else around it is quite dynamic and is subject to change. The terms that are used fairly often in the literature, it's infra-occlusion, infraposition, or submersion. And that's really just related to the direct change of the adjacent teeth that have over-erupted and resulted in the implant restoration remaining in a so-called infra-occluded position. And that's purely because the peri-implant bone has been arrested, and that just does not change. It's void of periodontal ligament and all of the simulatory factors around that, and that is why the implant would remain where it is. Thus, the implant supported crowns appears to be shorter than the adjacent natural teeth. So when you first read this, it does come across as the crown looks shorter. It is not shorter because obviously at the time of manufacture, it was made in the same height as the adjacent teeth. However, now with the incisal edges becoming, well, that have dropped, these teeth start looking shorter in that regard. A second consequence of this continuous eruption of teeth is the opening of the interproximal contact points between the implant-supported crown and the adjacent teeth. So it's not just the crown itself, we have a contact point issue. And the suggestion was that implant placement is the age when implant placement should be at the age when skeletal growth is thought to be completed. But we just said, we don't know at what age this is, 16 or 18 or 21. In practice, we generally try to say from 25 onwards, but we also now see with literature is 25 the right age. But the adaptive changes of the jaw continue, and the growth decreases steadily after the 2nd decade of life. But the published studies in the orthodontic literature indicate that growth or maturation of the facial skeleton continues throughout life. So I think even though we're using a few terms interchangeably here, the one term is continuous eruption, the other term is growth, the other term is adaptive changes, ultimately all of them are saying the same thing, that the oral cavity is physiological in nature and will be changing in whatever form it may be. So yes, there will be an argument that you stop growing. Yes, maybe you stop growing, but there's still changes. And that's ultimately the take home from all of this. So the two major consequences of this continuous growth is the occlusal migration of teeth, and the second is the open contacts adjacent to dental implant restorations. The open contacts are the ones that do cause bigger issues. If it's not an aesthetic concern, in this case, you start getting, you predisposed to secondary decay, periodontal disease, and food entrapment. So let's touch on the first one, the not so glamorous one, the one that we try to hide, avoid, and sometimes we try to almost really just dodge our way around patients, because an open contact, from the best of us, we all encounter this at some point in historical dentistry. There's a class 2 restoration on a molar, and you've got the contours wrong, whether you've been using the wrong matrix system, whatever it may be, but there's an open contact, and that patient would continuously be at your room till it's corrected. And in this case, it will be exactly that, because in this case, the slightly difference is the patient has paid a little bit more money for an implant restoration, and now there's an occlusion, and now there's an open contact. So going into the continuous craniofacial growth in patients in the anterior maxilla, the frequency here was phenomenally high. We're looking at 73% of patients have shown this type of change. There's no statistical difference between males and females. Yes, females show a little bit more than males, or more often than males, but however, 73% of patients are showing some sort of change in the anterior maxilla. And the most common concern is infra-occlusion, very highly, But the data, unfortunately, failed to identify a specific predisposing risk factor. The other concept would be the vertical eruption of the maxillary teeth, and this study was a 3-year follow-up study. And there's the reason why I showed, why I put up a 3-year study, because the changes are occurring and they're happening. And one of the limitations of the study said that it was 3 years. However, for me, this brought a lot of value, because 3 years is a short time, and that's really not enough for someone to close up practice, open up in the next suburb or in the next town. In 3 years, you're still there paying off your loans. And if these changes are happening in that short of a time, it's certainly something that we need to take heed of to make sure we avoid, prevent, or delay. And I think this concept would go through not just between us as restorative clinicians, surgeons, but also those that engage in orthodontics. Congenitally missing lateral incisors is probably one of the most common orthodontic findings, and that we need to treat. And there's obviously one school of thought: we bring the canines forward and close the space, or we keep the canines where they are. But ultimately, these patients have grown up without lateral incisors, and they've been promised at a certain age that they'll have braces done for them, and then we'll have those areas filled. And the rush, or there's always this notion of trying to hasten the process of completing orthodontics, placing the implant, and following up with the restoration. And I think we need to take it back a little bit, that yes, we can have the orthodontics completed, but the implant placement needs to be delayed for as long as possible. Obviously not saying leave it to beyond the age of 30, but we don't have to place implants in 18 or 21-year-olds. Another one, here we picked up, this study I particularly liked for 2 reasons. One, that the average age in this study was between the age of 21 and 78 years old. So it's really a large age group. And the other reason was that patients came up both from the USA as well as China. So some of the literature we end up looking at saying that patients came from a certain ethnic background, and that's why we saw this type of situation. But here we picked up patients from USA and China, and we've got a decent number as well. However, adult patients with implant-supported restorations in aesthetic zone displayed long-term changes that may jeopardize implant aesthetics. And now we're starting to see that this article is a 2020 article, and the wording is becoming a little bit more direct, that these changes may jeopardize the implant aesthetics. The magnitude of infra-occlusion was small, showing in most situations differences in the incisor plane between the teeth and the implant restorations of less than 1 millimeter. Commonly, a replacement of the implant support to crown will address the aesthetic concerns, but there's a cost. Who covers that cost? Was the patient aware of that cost? Because cost, regardless of the value, whether it's 1,000 Rand or 11,000 Rand, it's still a cost that a patient needs to be aware of. And I think something that we learned very quickly in private practice. In severe cases, restorative adjustments to the adjacent natural teeth might be necessary in conjunction with the replacement of implant-supported prosthesis. Now it gets even more interesting in terms of informed consent, because one of the main, call it, selling points or primary positives of implant therapy is that it's conservative to natural tooth structure. We are replacing what's missing with a prosthesis. If this patient had to arrive to us or return to us in 3 years' time, and the consequence of this occlusal migration is a bit more severe, and now we tell the patient that we need to do some sort of restorative work on the natural teeth, these questions will be asked. I was told that I wouldn't need to do it. Why do I need to do it? And now we start exposing ourselves to a lot more. I think we're also going to start seeing this type of phenomenon more often, because 20 years ago, we weren't taking as many photos of ourselves. We may not have been as aware or vain, but now there's photos being taken both in a private capacity, a professional capacity, and we also have the luxury of intraoral scanners that's keeping memory forever. It's not where the study models kept and we are discarding them after 5 years. But the conclusion here was that age and implant placement using a delayed approach were the only variables with a significant effect on the rate of implant infra-occlusion, meaning the younger the patient, which is obvious, and implant placement using a delayed approach, meaning delayed prosthesis. So there is literature that says that placing an implant or placing the prosthesis immediately does lessen the effects of the implant infra-occlusion. Another article in 2020, the case on the right-hand side also shows a 10-year follow-up. And this review of the literature did break down things quite simply in the sense that there's different factors that we're looking at. And age is definitely a factor for the infra-occlusion or the migration of the teeth. Gender is not a factor. Facial shape, not a factor at all. The effect of absence of the initial occlusal contact on continuous tooth eruption was not a factor, and the effect of the location of the implant within the anterior maxilla wasn't a factor. So if we look back at the patient that I showed earlier, here we have a male with a high aesthetic value, very high smile line. He doesn't propose to be a higher risk because of his smile line or vertical maxillary excess. It's really just the age. Implant was placed too early, and the consequence of this is now the occlusal migration of the adjacent teeth. This was a 15-month follow-up, and 15-month is frighteningly very, very close. It's literally the patient coming back, not even 2 years, and we start seeing this change. More often than not, if it's a patient that has a low lip line, it could be camouflage, it could be masked, we don't see it. But if it's a high smile line and we are showing a complete display of soft tissue as well as hard tissue, we have a problem. We have a very big problem, because if it's happened after 15 months, what do we have after 15 years? So conclusion in this aspect is simple. Occlusal migration is very evident in the second, third, but can last even into the fourth and fifth decades of life. Therefore, the submersion of anterior maxillary implants placed during these decades adjacent to natural teeth should not be a surprise. So meaning expect it. It will come to you. You will see it. The guy next door will see your work as well. Accordingly, it is very reasonable to delay placement of the anterior maxillary implant in the adolescent patient. Also, inform the adult patient about this phenomenon and receive a written informed consent before placing an implant in the anterior maxilla. I think ultimately, I'm not saying don't place implants. Hell, this evening is sponsored by Straumann Glue. I could never say that, but it's not the case. Implants are here. Implants are here to stay. We need to use them. They are incredible tools for replacement of missing teeth, but we need to approach them with caution and not ego. So the open contacts adjacent to dental implant restorations, because this one, if we're deeming I close my practice off, or if I had to say that I close my practice off to the easy implant work only, which is the posterior implant, well, I'm not going to have to deal with this. No, you will still have to deal with this, because there's a few factors that are causing this migration of teeth. So there's an anterior component of force, which is very often from the tongue and the lips, personal behavior, orthodontic appliances, periodontal membrane, and occlusal forces. And this is directly related to craniofacial growth. So there is literature that does show that there's mesial migration of teeth, and implants, because they are known to be ankylosed, are not moving. So very often with that mesial migration of teeth, we have now a diastema or a gap or a food trap, you know, call it, that develops between the implant crown and the adjacent natural tooth. Looking at the mesial versus distal open contacts, more often, and I think almost, I would like to say exclusively, but the mesial contacts open up more frequently, for the simple reason is that natural teeth tend to drift mesially. So implants are left where they are. The teeth that are distal to the implant or the implant crown will also want to tend to drift mesially. However, the implant is obviously there, or the implant crown is there. This will prevent that movement mesially. The maxilla versus the mandible, we see this opening contact or the opening contacts more often in the mandible. And I think this is directly related to just the method of the occlusal force, or the anterior component of the occlusal force that we start seeing. And there is also a very strong link between what restoration is in the opposing dentition. When there's a complete denture or a partial denture, the effects of this mesial drift or the opening of contacts is less prevalent than when there's a fully dentate arch. And this is purely because the anterior component of occlusal force has been reduced or negated at times. So just in terms of where we're looking at this open contacts, because it does sound to be a little bit bizarre at times, but this was from Greenstein's article. It was a 2010 bite wing, and the implant is placed at position 4-6, and we're looking at our tooth being 4-5. When a follow-up radiograph was taken in 2011, there was an open contact that had formed, and it was obviously left untreated at that time. Perhaps maybe it was not diagnosed, perhaps it was diagnosed and the patient was just reassured to say, keep that area clean. Whichever the reason may have been, we're not sure. However, in 2014, when the patient returned for follow-up, there was now secondary decay. So now we have the potential of pathology or the consequence of observing resulting in secondary decay. And I think regardless of how often patients are told to floss or need to floss, if there's an area that would allow food entrapment, secondary decay would soon follow. The results here were also quite astounding. For the migration of teeth, they were quite clear in that regard that it's something that we need to expect. And when I look at the literature here, in terms of the opening of the proximal contacts, we're looking in close to 58% of 58% in the 2008 study, 52% in the 2010 study, 67% of the time in the 2011 study, but fair enough, that was just 2 out of 3. The 2015 study, we saw 38%, and in the 2015 study, we saw 65%. So I think it's quite safe to say that close to half of your cases will return with an open contact. And we can't avoid it, or we can't change it. To illustrate the severity of it, and I picked this up in a 2020 article, at the time of delivery, which was on the left, and not too long afterwards, there's a definitive opening. And this is almost, I don't even think you'd call this a food trap anymore. It almost looks like one of those self-cleansing diastemas, if you're going to call it. But ultimately, this is something that the patient did not walk away with. This is not what the patient expected from treatment. And as soon as that sum of money has been handed over, there's always going to be a level of expectation or some sort of a guarantee long term. So I think it takes us back to the implants are in, but now what? Because we've either placed implants up until tonight or restored implants up until tonight, and we'll continue, but how do we manage the situation? So when it comes to open contacts, the possibility of future open contact should be communicated with the patients in all situations. So I think informed consent forms need to be changed. They should be changed and modified and add this in there as well. And the second thing is retrievability of implant restoration is strongly recommended. And it's strongly recommended, I think, from an implant perspective. When we go through implant training, we always talk about retrievability. We want to have screw retained because we want retrievability. And it's always this term that comes up. And I think sometimes we always tend to think that retrievability is there for maintenance. But what maintenance? Is it screw maintenance? Is it for hygiene maintenance? But in this case specifically, it's so important that we have a retrievable prosthesis just to manage an open contact or to close it. Yeah. Before impression procedures for implant restorations, the recommendation is modify both the adjacent contacts with minor recontouring, so they are flatter in profile and rounded with minor undercuts and rough edges removed. So in essence, trying to create an area where you, as opposed to having a contact point, you rather have a contact area. If there is an open contact with no food impaction, provide no treatment and carefully monitor the patient compliance. And I think this patient compliance, just the sequence of vitals that were taken, need to be taken routinely. So I think only the clinician would understand the type of patient or the level of compliance this patient has shown over the years to assess patient compliance. If there's an open contact with food impaction without pathology, the first choice is modification of the implant restoration. So meaning remove the implant crown, take another impression of that implant and modify that. Whether the material of the crown is able to be modified, there's obviously the risk of this crown fracturing or the abutment getting destroyed. These aspects do come in from the laboratory component, but ultimately we're looking at either modifying the implant restoration or fabricating a new restoration. If modifying is not possible, or we're not able to retrieve it, then the second choice becomes restoring the adjacent teeth or the adjacent tooth, which if it was a healthy tooth, a sound tooth, it's something that we shouldn't be advocating. If there's an open contact with food impaction as well as decay, modify the adjacent tooth with a conservative restoration or a new full coverage restoration to address the caries. And if there's a periodontal or peri-implant problem, this also needs to be addressed. So if there's already caries on the adjacent teeth or on the adjacent tooth, there's no need to remove the implant crown. By correcting the caries, we will reestablish contact. I think that's where a bit of honesty comes in the clinician's perspective, because now we need to think of what's our capabilities of class 2 restorations in terms of recontouring to closer contact and prevent this from becoming worse. But ultimately eliminate the open contact areas to preclude potential problems, especially in patients with a high caries rate or a history of periodontal disease, because periodontal disease will get exaggerated if there's obviously a food interruption and bacteria that's going to be aggregating or congregating in that area. For maintaining and monitoring, use a peri-implant maintenance protocol of 3 to 6 months, observe contact surrounding implants, and re-examine the occlusion in the area of the implant restoration. Once again, this would become a very subjective type of situation. So I think it's important that not only that photographs are taken in a standardized manner, but periapicals are also taken in a standardized manner, as well as if we have access to intraoral scanning, keep those STL files, which should always be on hand, or ideally, I think patients should be taking their models back with them, their implant models with the analogs and impression copings. So take another impression, have a model poured up and add this to the collection, well marked with the date. And then there's a very solid medium of reference of if there's been regression of the situation. So treatment strategies for the infra-occluded implants. Also a very recent article, but in 2015. I think this is probably the more simpler situation. The implant was placed at tooth position 1-1, and obviously the implant has remained where it is, hasn't moved. However, the natural teeth have dropped slightly. And the simplest suggestion in this case was a matter of gingival recontouring and placement of either a direct veneer or an indirect laboratory veneer, and our aesthetics would be corrected in that regard. And this is without adjusting the implant restoration at all. If there's the ability of correcting the implant restoration or reducing the contour or the emergence of the implant restoration and placing a soft tissue graft of some sort, then that should be obviously the first point of call. If that is not viable, then we should look at adjusting the adjacent teeth. This was one of the cases from Jeff, young patient as well, had some orthodontic work done, orthodontic relapse, but the implant was placed for the congenitally missing lateral incisor. In this type of situation, the practicality of what we spoke about in the first situation, which was some sort of crown lengthening or gingival recontouring and restorative work, is not possible. And this is where the effects become largely catastrophic. Younger patient, very different level of expectation, but high aesthetic value. And unfortunately, the only management in this situation is to remove this implant. Another option which the literature does touch on, as opposed to avoiding removal of the implant in its entirety, but it's still surgical based, is some sort of segmental osteotomy. It would require a very well-trained, highly skilled surgeon who's able to understand anatomy and limitations. but specifically to be able to remove the implant or move the implant in its entirety without breaking integration. High risk, especially in terms of location and just the patient's extraoral examination, but certainly an option that has been described in the literature. So I think it's important that we can start summarizing the extent of this infraposition or infra-occlusion, that there would be either none or mild, and here we need to start looking at maybe just being very conservative, either just build up the implant restoration and manage and assess as we go from there. However, if it becomes moderate, meaning less than 1 millimeter, but greater than 0.5 mil, when it starts becoming more apparent, then we need to look at the adjustment or the replacement of the implant restoration. And then greater than 1 millimeter, it becomes severe. We're looking at surgical implant repositioning or segmental osteotomy, possible with some sort of distraction, or looking at submerging the implant in its entirety and fabricating perhaps a 3-unit bridge, or looking at implant removal, major soft tissue and hard tissue augmentation, and a staged implant approach. I think the one thing that I would take from this, and on screen here, we have a bone level implant and a tissue level implant. And tissue level implants show amazing success rates. And I think I've even seen literature where they've used tissue level implants in the anterior maxilla. I think given where technology has gone and where the literature is showing that there's going to be some sort of midfacial growth, maturation, development, I would potentially go as far as saying that maybe tissue level implants should be avoided in the anterior maxilla, just for this reason. Regardless of whether the position of the implant is ideal, screw access hole is coming out on the palatal aspect, I think just for this reason, it's something that we're never going to be able to avoid, hide, or mask. And the treatment for a tissue level implant will be, unfortunately, on the more severe spectrum of the treatment options. So I'm going back to this case again, because if it's a clinical failure or a subjective failure, because this patient actually didn't come to me willingly. He went to his local dentist for his regular cleaning, and it wasn't his regular dentist in terms of his long-term dentist. He just moved into the area and he found the local dentist and he went in for his regular cleaning. And the dentist saw this and the alarm bells went off, that things are going really bad here. And this guy walked in extremely chilled, relaxed, not concerned about anything actually. And he just says, like, my dentist seems concerned about this. What should I do? Should I do something or should I leave it? So you never win with patients, I guess. But I think ultimately we know that the situation will only get worse. And I think that was what my comment to him was, that what he has here, it's only going to get worse. And yes, in terms of how much worse it will be, it's really relative, because ultimately now we have this almost going all the way up to his lip. What my bigger concern was that he's already started losing bone around this implant. And the longer this goes on, he starts losing more of his native bone. So how much of a clinical significance that would play for the surgeon that would be treating him, I'm not sure, but it is a matter of concern, because this implant currently is sitting on 2 to 3 mils of bone. But I think what does keep things quite encapsulated, because patients generally, and I'll be the first to admit that we see this very often, we're dealing with a lot more emotions and very little fact, because patients are coming with a lot of expectations not met, the stigma of poor aesthetics, the financial repercussions of this failure. They feel they've been duped, they've been lied to, there's been fraud. There's multiple emotions that are coming through here, but I think if we're able to encapsulate all of the emotions into fact, and then it makes treatment a lot easier. So I think from this 2019 article, the awareness and perception score form seem to summarize things quite well. Because the first thing is, have you recently noticed some aesthetic problem or appearance with your implant retained crown or crowns and the surrounding gingival tissue? And if the answer is no, you don't really need to go on beyond that. But if the answer is yes, then you go on to question 2. If you answered yes, what kind of problem did you notice in respect to the adjacent teeth? And then we listed in terms of the tooth or the teeth presents some sort of color problem. The tooth appears longer or shorter. The gingiva appears discolored. The gingiva has moved upward. The gingiva among these teeth are shrinking. And note that the word, especially in point D, the gingiva has moved upward. After looking at what the literature says and the imaging, the gingiva hasn't moved upward. It's just that all the other teeth have moved downward. But here it's just for us to try and get into the patient's mind as to what exactly are they feeling. If anyone wants access to this article, I'll be more than willing to share it at the end of this presentation. If you notice the tooth or the teeth being shorter, do you consider this an aesthetic problem? And the answer is either yes or no. If you answered no to question 3, would you like to understand the reason for this? And if you answered yes to question 3, would you like to have it fixed? And I think once you've come to the end of question 5, then it's regardless of what treatment option we choose, the patient now needs to be aware of all the options that are at their disposal. And it can't be palliative care. The first case, this one here again, this patient was treated palliatively. This crown was changed twice since the time the initial crown was done. And all the previous restorative clinicians did was just add a bit more pink and added a bit more pink. And to what end? At what point do we say that we're not going to add more pink? We need to stop and start all over again. And I think this is something that we need to be very honest with. And ultimately, this is the risk of implant dentistry that we need to take on the chin. So going back to A.B. de Villiers at the start, and one of the most resounding bits of the lecture from Jeff in 2019 was the most dangerous term in dentistry is that we've always done it this way. And if we apply this notion, and regardless of implantology or restorative dentistry, we are looking for trouble. We're going to get ourselves into major complications. And I think that's where dentistry stress will just go up. And I think the first thing on the top of my mind comes in that if we are preparing full coverage crowns because we don't believe in veneers, and if the answer is we've always done it this way, it's equally comparable. If there's a more conservative approach, we need to adapt it. If we are adopting implant therapy, fully dentate patient, missing a single anterior tooth, and we've been placing implants over the years, we need to change our informed consent or the medical legal aspect of our practice and make patients more aware of it. Because after 15 years, yes, we can technically, we will be recharging or rebilling these patients again for treatment. But if after 15 months, it becomes a bit more of a difficult ball to dodge. So in terms of my concluding remarks, biology versus technology, it's not about one being better than the other. We need to find this halfway point or this common ground where we respect biology and we embrace technology and move ahead without compromising patient care and patient satisfaction. This is a clinical phenomenon that is unavoidable, regardless of the patient's demographic or lifestyle. Just by the mere fact of aging, it's something that we will encounter. Delay implant or fixed prosthodontics as late as possible. And this would be as late as possible, but as early as necessary. So once again, I'll be as ambiguous as what the literature was, but I think the gut feel is quite a reliable source at times. And regardless of how much of experience we have or how little experience we have, we know when situations will, or we should know when situations would be giving us trouble. Informed consent, I think always written. Whether you've said it or your nurse has heard it, or the patient's companion or the patient's guardian has heard it, that is irrelevant because amnesia is a real situation in a dental practice and it occurs on a daily basis. And a written informed consent is something that no one could ever contest. However, there's only one guarantee in dentistry, and that's complications. Complications will always occur. It's just a matter of the magnitude of the complications that will occur and how will we correct it or manage it later on. I think the one aspect of why you start thinking a bit more conservatively, especially when you start looking at treating patients on specialized dentistry, you start realizing that dentistry makes its business out of failures of previous dentistry. If a patient had to brush their teeth twice a day and patients had to floss and use a mouthwash and did everything that we tell them to do, they'd never need the dentist. They'd never need to have restorative work done. But as soon as there's some sort of human intervention into the oral cavity, some sort of complication should be expected and would be expected. And how do we manage this? And I think I was telling someone just recently, the way we need to look at it is that the ability of carrying out a procedure is not how well, this is my opinion, the ability of carrying out a procedure is not how well trained you are in that procedure. I feel that the ability or your competence in carrying out a procedure is directly related in your skills at managing that complication. And if you are not able to, not you, myself, or anyone, any clinician is not able to manage the consequence of that complication, then we shouldn't be carrying out that procedure. Because ultimately we are going to be held accountable, whether it be to the patient or to a higher power, to whatever work we've done and on what merit was that work carried out. So something that I started taking a liking to, it's the Dunning-Kruger effect. And basically this graph is basically talking about, it's a type of cognitive bias in which people believe that they are smarter and more capable than they really are. So in essence, that when we actually feel the most confident about a procedure could very well be the time when we lack complete wisdom. And the time when we feel that we feel like we're not sure we're not doing the right thing, we're actually on the right path, because that is the path that's taking us to enlightenment. And we hope to be in that plateau of sustainability at some point. The height of this curve, or the height or the peak of Mount Stupid, we can control that. And that's really just an ego thing. I think dentistry is an ego thing. It's something that we aspire to do more, but how much have we empowered ourselves, or on what platforms have we empowered ourselves to do more? And have we seen the recall or the recourse of the work that we've done to say that we are doing successful long-term dentistry? I think that's something that only experience will bring. I still have many years, so my dad says people in glass houses shouldn't throw stones. So I think only time will tell where we're at. But I think the more that we realize that we are men and that we are prone to consequences that of what we put out, we will do less. I think the more you know, the less you do. And that's really the space that we want to be in. Thank you. I hope that I've answered some questions and left you with more questions, because that is, I think, ultimately the goal or the aim of where I try to take this lecture, that we really just need to address these situations with caution before just diving in and acting freely. Thank you. Thanks for your time and thanks for your attention. Talia?
Thanks, Ridhwaan. That was great. We do have a couple of questions and comments in the Q&A. And let me start with, right, this is an age thing. Let me start here. So we've got one, don't you laugh. So we've got our first question here is, do you generally think that implants go hand in hand with a localized inflammatory response with unavoidable infection with time? This situation leading to a chronic inflammation over a period. If you agree with this concept of this foreign body induced inflammation, what effect will the prolonged ensuing chronic inflammation have on the general health of the patient?
Well, okay, that's a loaded question.
It's a long question, yeah.
Yeah. Well done on reading it out so well. I think the first point that I would like to touch on is that an implant is made of titanium. The most common implants are made of titanium, and it's biologically stable. So ultimately, an implant that is inserted in the correct case, under the correct circumstances, in the correct situation, shouldn't be we shouldn't say predictably it will develop some sort of peri-implant peri-implantitis or peri-implant mucositis. If the patient has been chosen or selected correctly, that situation shouldn't occur. So by no means, I think if we know that we're placing implants that will develop some sort of peri-implant disease, we shouldn't be placing it because it will fail. The failure will result in obviously localized bone loss and make future implant placement almost impossible. However, I do acknowledge that in any situation, if there is a localized acute infection, even a chronic infection, 100% there would certainly be some sort of effect on the greater systemic health of the patient. And vice versa. And I think that's exactly, if there's a patient has a systemic health issue, that would result in a higher predisposition to implant failure or peri-implant disease. I don't know if that answers the question, I think.
Right. Next one is something simple. Do you actually still just do plain old-fashioned dentistry, i.e. fillings in your practice? Our participant seems to feel that a lot of salespeople come to him, and I assume these must be implant salespeople, and say it's just much easier to place an implant rather than to do a class 2 filling. But not everybody can do that well. So what's your feeling on this?
Talia, if it's one of your reps, I think that you find them, you hunt them down, and you reprimand them.
Absolutely.
Yeah, one of those.
Totally
Okay.
agree. Totally agree. Totally agree.
So if your rep is listening in tonight, stop doing that. I think the first thing with implantology, and I should have touched on this, or I should have made greater emphasis on this, that an implant is a replacement for a missing tooth. It's not a replacement for a tooth. So ultimately, if there's a tooth in place, every means possible, whether it be a class 2 restoration or it be orthodontic extrusion or crown lengthening to obtain more ferrule and endodontics, we need to explore all of those options prior to placing an implant. And I think this is exactly a simple question, but such a relevant question. Thank you for posing the question, because it opens us up to something that I should have touched on, that in essence, as opposed to freely extracting a tooth and placing an implant, knowing after what we've seen in tonight's presentation, we should be exploring all of those options prior to that. Because being in that practice where you're only able to do a class 2 and not do an implant, you're probably doing more benefit to your patients than the guy down the road who's extracting and placing implants empirically. Yeah.
Yeah, totally agree. It's implant isn't the solution to all your problems. Question over here: why don't you do occlusal guard flat plane?
Oh no, we should. I think occlusal guard flat plane is something that we should be done. That will also, the literature also does touch on that the occlusal guard does lower the anterior component of force, so it will reduce the effect of the mesial drifting or the mesial the open contacts. However, it's not completely avoidable. It's one of the suggested tools of doing it. But as you can see, the literature comes through from just early 2000s. So now that we've accepted this as a phenomena, more studies with greater sample population need to be looked into, where we actually use a flat plane guard and see what the consequences of it. I think this aspect of looking at individualized biology makes it quite difficult for evidence to be populated on it, but it is one of the recommended means of reducing the opening of the contacts. I don't think that the occlusal guard will reduce your effect of your infra-occlusion, because if teeth want to drop, they'll drop, and the guard isn't a rigid splint that's holding those teeth in place. So yeah, will work in the one or show some sort of improvement in the one, but not in the other.
Charles has made a comment over here and a few comments down. He's actually got his answer to his question, although he still has another question. So he basically wanted to know how often is migration noticed when placing anterior implants. But then he does say he got his answer plus minus 50%. But he seems to feel that it doesn't reflect clinically, though. What do most of the other people say? What do you feel about this?
Okay, so in terms of the migration, the mesial migration was seen on average about 50%, 50-60% of the cases. The occlusal migration or the infra-occlusion of the implant restoration, the one study picked up as high as 73%. But that migration, there's no set timeline on that. There's times when we see it as early as 15 months, and there's times when we see it as long as 10 years. And the amplitude of that migration can be as little as 0.5 of a millimeter to completely clinically disastrous. So I think also it's really just being assessing in terms of timelines and grouping patients. It's not a matter of tomorrow morning, you're going to look at all our implant patients, and if we don't see 73% of it, then the literature is wrong. It means that there's the risk in a certain timeline. And as well as age, because I'm sure if we look at the article where they showed 73% of occlusal migration, I'm sure a greater part of that was in your younger population, because the second and third decade of life show the higher incidence of this migration.
Okay. This is an interesting one. How would you approach the, no, but it's true. How would you approach the subject when a patient comes to you and you actually need to tell them that they either need to redo, replace an implant or an implant crown in a very short time period, which medical aids obviously won't cover the cost of such revisions?
I think you say it just as your mommy taught you to say it. You speak the truth, the whole truth, nothing but the truth, and you be very honest about it. I think that's the only way. But I think a lesson that I've learned from someone quite recently as well was that something said after the fact is an excuse, and something that said before the fact is the reason. So if there's informed consent that's carried out prior to that implant restoration, and you tell this patient you are 25 years old, there is a high risk of this migration occurring. The literature shows us. We've shown some photos or images of what can happen, and then the patient makes a decision. Then that conversation that occurs when failure occurs or the complication occurs becomes a lot easier. Dr. Krunling always says, you got to hand over responsibility to the patient. I think dentistry and life, we take on a lot of our own stresses, and it's unnecessary for us to try and take on the patient's stress as well. And I think this really also puts you in where you're trying to fit your patient or your practice model. If you're trying to sell treatment plans, then you're obviously going to be really just taking on a lot of this pressure because you're not telling patients. But in this case, it almost comes across as contradictory, because we're almost telling a patient or advising a patient on a treatment plan, but at the same time, putting ourselves at risk that the patient may say, I don't want the suggested treatment, which I think Blackie always used to tell us that some of his best results were the ones where patients rejected treatment. It's for the simple reason that you've dodged the bullet, you've dodged the complication, or you've delayed it later on. Because ultimately that patient will come back. The patient will come back, the patient will refer someone else to you just because he's an honest guy or she's an honest female. Yeah.
Ridhwaan and Norman would love to know, what is your feeling on buccal shield implants that are placed, this technique? Do you know it? Does your surgeon use it? Because there was a nice lecture from SADA a couple of months back on this. If you could just give us a quick rundown on that.
Okay. So the term, I'm assuming that he's referring to socket shield.
I would assume, yeah.
So it's also a very good question. It's something that I actually was scratching around last night to see if there's anything on it, because I was expecting a question like this to come about. The simple answer is we don't know. If you look at the literature on where we have with standard implants, we're still looking at the effects of the implants that we placed 10, 20, 30 years ago. I think Howard and his group have just got their recent results now. And I think the more data they get, the more results we will get. So right now, there's not anything conclusive on it, but I think the one thing that we can accept that there would be some sort of biological change that would occur. can always chat to Howard and see what he says. I don't think he's in here tonight, but I think from the simple thing of it being biological, there would be change. I think where it becomes interesting with socket shield is how to manage the complication of that. Because I think one of the surgeons that I work with, for him, so for him says also, and his opinion is that even the migration of that shield or the coronal migration of that shield would be restricted by the abutment or the position of the abutment or the implant abutment. So would that lessen the effect? I'm not sure. Good question.
Yeah.
But there's nothing in the literature. I haven't picked it up. I haven't read anything on it. So I think if I say anything, it should be based on literature. Yeah.
Another one, yeah, and I must bite my tongue here. Should implants be placed if you don't have a 3D scan, if you don't use surgical guides, even if your patient signs informed consent under the impression that the clinician will be following these recommended guidelines?
Our Hippocratic oath was do no harm. And placing an implant without a surgical guide, without a 3D, we are putting ourselves and the patient at risk of harm. There's also that term that we don't talk about enough of is called good clinical judgment. And placing an implant without a 3D guide defies good clinical judgment. So regardless of consent, we shouldn't be doing it. I guess it's the same thing. The patient signs that I'm going to pay your entire bill of 50,000 Rand at the day of delivery, and are we going to start treatment? But I've signed up, I promise I will pay it without a deposit. No, we always take a deposit because we don't trust. So in the same way that we're doing it in that, we're running your business in that way. You should run your clinical practice in the same way with good judgment.
Dr. Patel wants to know immediate loading versus conventional approach. Do they fail more?
Good question. The literature does say, funny enough, and I'm not sure exactly why because there's no reason for it, but immediate loading of single crowns shows a lesser effect of the occlusal migration of these teeth, or the effect of that. For some reason, the delayed approach, it's largely a lot more exaggerated. I'm not sure if it's because of the soft tissue relationship that we start developing quite early on, as opposed to working with soft tissue that has already matured and potentially migrated apically. I'm not sure, but definitely immediate or early shows less of an effect of it. Yeah.
Here's a question, and I think it regards to a previous question that we've already discussed. Is it physiological changes, thank you, sir, or adaptive changes? For example, adaptive is occlusal stability. So if the occlusion is stable, would age or other factors mentioned play a role in complications?
Nice question. Playing around with the words very well. So I think both terms go hand in hand. If the occlusion is stable, there's still the effect that we will see, which is physiological. So physiological is just innate and natural, and that will occur. So for example, if the occlusion wasn't stable and there was no opposing dentition on your implant crown and natural tooth, then your effect would be reduced. So I wouldn't call it adaptive, calling it in terms of the localized effect. I would just call it physiological adaptive, but rather in the very generalized maxillofacial situation, because that adaptive change is not looking at just the teeth, it's looking at your maxillofacial structures as a whole. And I think also in the same way, if there's occlusion, you also have a TMJ joint or a TMJ. And that in itself would have an adaptive change in some patients to the dentition. So you have an stable occlusal plane today, and the patient develops some sort of TMD, then your stable occlusion goes away, or the effects on your stable occlusion goes away. And I think also, how do we define stable occlusion? That's an entire topic in itself, in terms of centric or functional, dynamic. What is stable? So it is really a case-by-case type of situation.
Yeah, a question that I think as salespeople, they often get asked this too. Would you place an implant in a patient's mouth that does have perio in certain areas of the mouth, but not where you're going to be placing this implant?
As a salesperson, how would you answer that question?
No. Clean up the mouth.
So I think the crux there goes to what was the diagnosis and the etiological factors that resulted in that perio. Because localized periodontal disease is a phenomenon that is well documented, and it doesn't mean that localized periodontal disease would result in generalized as well. So again, I think it's where you got to engage with your periodontist with what is your specific diagnosis, because periodontal disease could be bacterial, or the periodontal breakdown could just be because of over-contoured restorations. It could be because of food impaction. And those are not reasons to not place implant in the opposite side of the mouth. So I think a very clear, specific diagnosis on that before placement. But I think on paper, I wouldn't use that as being a contraindication for implant placement.
Okay. And then I think we're coming to the end of our questions now. Just going back to delaying the placement of an implant. What about the bone loss with that?
I think the consequences of delaying, okay, so I think if we're looking at bone loss, now we're talking more specifically, I'm not sure, has there been a tooth or is there a tooth that needs to be extracted before we place an implant? And if we're looking at delaying it, then I think the question earlier was socket shield. The converse of socket shield would be Pontic shield. So as opposed to doing a complete extraction, we could engage in some sort of partial extraction therapy, which will preserve the bone, will allow for that continuous stimulation of the bone up until which time we are ready for an implant placement. So either engage in some sort of partial extraction therapies or some sort of bone preservation modalities. And I think this is where that direct line of communication between restorative clinician and surgeon needs to be engaged in. Because even if we're looking, and if we're talking from a general dentist perspective or a prosthodontist perspective, if we only feel that an implant will be needed in the next 5 or 6 years, and if in your practice you would engage in simple extractions, rather let that extraction be managed by your surgeon who can plan for the way he'd like his implant to be placed in 5 years' time. So, but then again, if you lose bone in the next 5 years, it's a small consequence. Graft it and place an implant and deal with that, rather than placing the implant too early and risk the potential of needing to remove that implant, the cost and the embarrassment and the loss of credibility that'll follow with that.
Mm-hmm. And there's a lot of thank yous, and I think lastly, just Norman just wants to know, do you know the program of Aaron Garg from Florida? Do I pronounce his surname correctly? G-A-R-G. He was around between 2014, 2015, did some sort of a program. Do you know if much has changed from there? If you don't, then I think we can answer this privately.
Yeah, I'm not familiar with that, unfortunately. 2014, 2015, I was still a spring chicken trying to get into prosthodontics. Yeah, unfortunately not. I'm so sorry.
Ridhwaan, and then I think that's it. Looks like it. Hold on.
One more.
Is implant placement contraindicated in patients with autoimmune diseases like rheumatoid arthritis?
I actually had a patient that presented with that recently. I think autoimmune diseases, I stick my head out there and say, I won't say it's contraindicated, but a relative contraindication. I think that's probably why I chose not to be a surgeon. So you're able to answer these questions in a very ambiguous manner, because the literature is quite clear on certain definite contraindications. You're looking at your bisphosphonate patients, your radiation patients, and your uncontrolled, like diabetic patients, but the rest of it fall into this category of relative contraindications or that gray area. So refer to your local surgeon, let it be his problem than yours.
Yeah, nice. And yeah, just a lot of thank yous. Thank you. Hold on.
Yeah, I think thank you to everyone for tuning in tonight. I really appreciate it. It's always humbling to be on a SADA webinar and you see the numbers creeping in over 400. So it's always a humbling experience to see something like that. Yeah.
Yeah, thank you, Tels. Thank you, Ridhwaan, for very informative talk this evening. It's great to have somebody who is so honest about their journey. You're passionate about learning and sharing. And of course, it's very evident that you care about your patients too. So big thank you to all who attended this evening. We did get up to about just under 500 at one point. So that really shows that there's a lot of interest out there. So thank you, Sada, for hosting us all. Thank you,
Straumann, as well. Thanks a lot.
Good night.
Good night.
Imagine creating millions of smiles. Imagine helping people look good, feel good, and enjoy life. Imagine making people's lives better every second of the day. Imagine inspiring thousands of talented professionals worldwide who serve more than 200,000 customers in over 100 countries. Imagine pioneering, empowering, and partnering with dental healthcare providers worldwide. That's what we do every day. This is what drives us and fills us with passion. Driving breakthroughs and exploring new ground for more than 60 years. Our roots are recognized as a leading innovation and quality brand in dentistry. Innovation that's backed by scientific evidence, legendary Swiss engineering, and precision. We want to push the boundaries to enable the next generation of dental care. Welcome to the Straumann Group. With our brands and partners, we're even more committed to global dental care and excellence. Through innovation and excellence, we make better dental solutions available to more people to deliver more smiles. Education is the foundation of our success, together with the largest dental scientific network worldwide. We provide an inspiring working environment where talented people can excel, so that we can achieve our goal to be the leading global provider in aesthetic dentistry. The Straumann Group, a powerful combination of great brands. We are Straumann, the global gold standard in implant and aesthetic dentistry. Progressive dental solutions combined with affordable economic value. We are Medentika, prosthetics perfected, engineered and made in Germany. Clear Correct. Clear, simple, friendly. We've combined all of this expertise into one global group, based on a pioneering culture that promotes creativity and learning. We unite global reach with individual talent, experience, and identities on a remarkable journey. Our inspired professionals are committed to delivering uncompromising quality. we take an holistic approach that goes beyond implantology. Straumann Group, united for global excellence in dentistry.